And our last speaker is Dan Henning. He's going to talk about transcription factor inhibition.
Thank you for the opportunity, Dan, and the group here. I want to continue with the, now for something completely different, theme. This compound is quite a bit different and similar to what Bill just presented. We are very specific to not call it an analgesic. This is a preventive agent, and you'll see why. It's also, though, we're about to start our 4th clinical trial with this agent, so it is advanced quite considerably. To just introduce the company, Dynex is a small biotech, 7 people, and this material has been advanced from IND in 2012 to now the 4th clinical trial in 2016. So I'll give you a little bit of the flavor of that as we go forward. First, let me give you some background. What we approached here was that, as we've been hearing all day, multimodal analgesia has a number of components. They've been mixed and matched, and not everybody is agreed on what the exact components are. But what often is not discussed, and most of the acute pain postoperative trials are dealing with 48 hours, 72 hours after surgery, particularly looking at pain at rest, occasionally pain with movement. What we really wanted to focus on was this movement-evoked pain, but also to prevent the chronification, which is a horrible word, to prevent the development of chronic pain after surgery, which is still a very poorly addressed topic in general. So when you look at the progression of action here, one has the baseline nociceptive state. This is what we need to intervene with anesthetics. Local anesthetics change the threshold, change the activity here. With low-level, moderate-level stimulation, you get activation, sensitization of the nociceptive system. You get a wind-up. This is equivalent in many ways to early long-term potentiation, early stage. With a strong enough stimulus, and we're talking now in the 30 hertz and above stimulation in a C-fiber system, you can push the system over to the late-stage long-term potentiation. The difference between this panel and this panel is a change in phenotype of the nociceptor requiring new protein production. The analogy here is memory, going from short-term memory consolidation into long-term memory. And for many years we talked about chronic pain as being a memory for the trauma that just doesn't go away. What we have approached, because we're working on transcription factor inhibitors, is that this new protein expression is a very coordinated component of the response to trauma. And whenever you have a coordinated protein transcription event, you need to coordinate it with transcription factors. So the transcription factor that was identified as being critical to this process is early growth response, EGR1. It does a number of things in the body, but in the spinal cord dorsal root ganglion complex, there's virtually no baseline expression of this protein. However, once a high-intensity stimulus occurs, and in this case, it could be electrical or surgical, a number of physical or inflammatory stimuli, as well as a number of inflammatory and chemical stimuli, including prostaglandins, e.g., NGF, and so on. This is an integrating protein. All of these stimuli and agents have been shown to have an upregulation of EGR1. But the important thing is this integration. Look at the products that it regulates, about 2,000 genes. It's everybody's hit list for what an analgesic program should look like. But what's interesting about it is those items in red are down-regulated. How do you deal with a down-regulated gene with a therapeutic? In fact, the down-regulated genes are interesting. Some of them are proteasomal, so that you end up preventing protein degradation, which includes GABA receptors and other inhibitory pathways. Also, you have upregulation, voltage-gated calcium channels, a number of mediators for inflammatory pain. The idea is that the pain system in response to trauma is degenerate, in the sense that there's huge overlap, and any one narrowly defined target is not going to go that far in a clinical setting. That one needs to get a very blanket coverage, and we all know the dirtiest drugs are the best ones for analgesic effect. Why is that? Because there's multiple end products that we need to address. It's also partly the reason why multimodal analgesia is better than single agent at a time. So our purpose in designing this agent was to inhibit this pathologic upregulation of EGR1 and prevent the pathologic change in transcriptional program inside the nociceptive system. And the way to do that, the most established and potent way to inhibit a transcription factor is through the use of a decoy. This transcription factor binds with high specificity to a specific sequence on the genome, where it then attracts the transcriptional machinery. The binding sequence is 100% conserved across species with this agent. Now we know it wouldn't be that dangerous to interfere here because knockout animals are normal, except that they don't develop sensitization after injury. So how does one approach this? In fact, it's to make a replicate of that genomic binding site. So the agent that I'll talk to you about, AYX1, is a 23 base pair double-stranded DNA that is not protected against metabolism. It is naked DNA. The only thing that it does is bind EGR1. What was done is to overlap the binding sites in such a way that the affinity of AYX1 for the transcription factor EGR1 is about 10-fold higher than the genome is. The other point of EGR1 is that it's immediately upregulated after injury, but only for 24 hours. It's a switch. When EGR1 is present, it triggers this pathway of gene transcriptional change. If you are present for the period of time that this is expressed, you will not get that change. It is preventive then. And in fact, that's the paradigm here, is in the presence of AYX1, you bind EGR1 and prevent it from getting to the genome. It has about 12 to 24 hours local concentration. Keep that in mind when you see the results. And the other important thing is it's administered intrathecally. The cerebral spinal fluid has very low capacity for nuclease enzyme activity, whereas the serum has a very high level. So in the CSF, AYX1 has about a 2-hour half-life, in the plasma about 2 minutes. So through a number of preclinical studies, we arrive at the most recent clinical study. We're about to start the follow-up study this month. We used total knee replacement as a model, already receiving an intrathecal injection, high issue with mechanically evoked pain, and also about a 20% on average incidence of chronic pain. We took the standard model of adults undergoing unilateral therapy. We had a standardized anesthetic, fentanyl, midazolam, propofol. Bupivacaine is the spinal anesthetic. The spinal needle was placed, AYX1 was injected, and then it was followed by the bupivacaine. Postoperatively, the person received all the opioid needed to get comfortable in the post-op period, were put on briefly on an IV PCA with no basal, and then converted to oral opioids. In this particular study, we did not allow NSAIDs up to 28 days. We did not allow gabapentinoids. And there were no nerve blocks in the study. There were 2 investigative sites based on the previous study. These enrolled a large number of subjects and we were able to minimize variability. The main endpoint was pain with walking, and we chose it over the 7 to 28 days. Why that period? If you remember that 3-panel slide, the time it takes from trauma to the expression of late-stage long-term potentiation is approximately 48 to 72 hours. So we did not expect much in the first 48 hours. That means we don't replace intraoperative anesthetic. We don't change the first day or so of analgesic therapy. It's after that point where it works. The general results were that the opioid utilization was equal in both placebo and active group up to 28 days. We did not tell the surgeon or the patient how to take the opioids. We saw evidence based on pre-dose pain scores that they were taking it on a schedule. We were getting 0s and 1s before they took the opioid. But after day 28, there was about 30 to 40% reduction in opioid use in the active group. Going forward, we will be more specific with the subjects and the surgeons about only using as needed. The other point to look at when you see the data is that 98% of the subjects that were dosed with AYX1, single preoperative dose, were present at 42 days for evaluation. So attrition bias nor differential opioid use do not account for the results you see. So here are the data for pain with walking, so a movement evoked pain postoperatively. And you see at 24 and 48 hours, basically they overlap, very consistent with the mechanism of this compound. We did weekly clinic-based visits to observe the person and encourage them to rate only the pain in the operative knee. These are walks of 15 meters. And you see that at the first post-discharge appointment, there's quite a separation between placebo and active that maintains for the entire 42-day period. What you need to notice from here is that this is not your typical post-op pain study where you have a baseline pain and you drop a number of points as a drug effect, and then you have a placebo that drops the next number of points. These are group differences, and I'll show you where that's significant in a moment. And the pre-specified endpoint was the pain with walking 7 to 28 days area under the curve. Now, we expect a change in movement evoked pain. Remember, this is a single injection here that has a half-life of 2 hours. We're seeing effects that are out to 42 days. It's because of the preventive paradigm. If you don't allow EGR1 to have its effect, you will never see that effect until the next surgery. A little bit surprising was, given that this was an optimized opioid regimen, you would think opioids help with pain at rest. In fact, we still see a benefit in pain at rest, perhaps larger. Again, similar time frame and lasting through the entire 42-day period. Those are means. Another way of looking at this is responder analysis. This was now a post hoc analysis. We plan to go forward now with more detailed information in the next study. This is defining adequate analgesia as less than 3, and look at the proportion of patients in each of the groups at each time point. And you see after 48 hours, virtually every time point for pain with walking or pain at rest, there was a higher percentage of people in the treated group than in the placebo. What this suggests to us, but does not prove, is that we change the course of the postoperative pain, the ability to reach adequate analgesia in the mild range faster with the treatment than in not treatment. What we plan to do in the next study is we'll still do the weekly visits, but we're adding electronic diaries here, so that we'll get daily data. We can do time to event analysis to truly look at the slope of each of these curves. But you notice that the active curve approaches 100%. Remember, the incidence of chronic pain in knee replacement is approximately 20%. When you look at the data for pain at rest, and that's predominantly rest or average pain is how the chronic pain is assessed often, you see that the active group has 3% incidence of pain greater than or equal to 3 at day 42. Whereas the placebo-treated group with a fully loaded opioid regimen has 21%. But it's even more dramatic if you go to pain with walking. 5% in the treated group, 32% for pain with walking. But then people will argue that, well, okay, you're into the mild range already. Let's look at the border between mild and moderate. So greater than or equal to 4, and notice at 42 days, it's 0 incidence for the treated group, it's 21% for the active, or for the placebo. But also notice that it's not just cherry picking that 42-day time point. If you look back progressively at earlier time points, you see that separation appear much earlier. In the subsequent study, we need to take this out to 90 days for the regulatory definition for chronic pain, but given the nature of chronic pain after surgery, we would not expect this to change much. And in fact, the literature is quite clear that 30, 42 days after surgery is very similar rates to 90 days and greater. You have your pain, it's not resolving right away. These data, to my knowledge, has never been seen with any other agent, and especially an agent that's only around for about a day after it's delivered. The adverse event profile, in animals, the no AEL, the no observed adverse event level, was the limit of how much we could stuff into the animal in their intrathecal space. We have not been able to identify a specific adverse event related to this agent. Interestingly, when we looked at these data, the one that jumped out at us is procedural hypotension. Now, you have a spinal anesthetic. This did not show up in the phase 1 healthy volunteer study, did not show up in the previous clinical trial, but in fact, the incidence of any hypotension, the reason that this gets labeled that as oppressor is used, the incidence in the literature is 30 to 35% of the spinal study. So in fact, we think what the abnormality here is this 5% in the placebo, and that will be fleshed out as we go forward in bigger studies. But this was transient, never occurred again. The other big imbalance is post-procedure shivering, an imbalance in here, but again, it's a low dose imperative post-operatively, never a return. In general, the rest of the adverse events played out. These are any adverse event over 42 days. Now let me talk about the difference. This is not the paradigm that one is used to seeing. Group differences prevention. So one way of trying to look at that is the standard effect size. And you notice the formula here, the treatment group minus the placebo group over the pooled standard deviation. It's one that's been published. And if you look at the standard effect sizes for NSAIDs, opioids, you're in the 0.53 to 0.55 range. Now if you look at the data for AYX1 at various time points, or certainly in the 42-day point, the pain with walking standard effect size is 0.69, whereas the effect for pain at rest is 1.0 compared to the 0.53 average for the standard acute pain therapies. So it's one way of looking at this effect even on top of an opioid regimen. So in fact, it's probably not overstating it to say that this doubles the effect size. What we expect to see in the subsequent study is that we will look at 100 subjects with active, 100 on placebo, but now we very specifically inform both the investigators and the subjects that one is to use the opioids only as needed and specifically tell them not to use it on a schedule. You notice that the change at 28 days just happened to be the end of the prescription for an opioid, and you needed to use them less frequently afterward. So we fully expect that we will see changes with the opioid use going forward. We've also allowed NSAIDs down in the next study, and we've allowed infiltration of local anesthetics. Because again, as you saw from many of the presentations, the interventions for acute pain post-operatively have a utility for about 24 to 48 hours. That doesn't interfere with the effect here, so that now by adding back the rest of what would be standard of care, we can still peel apart what happens in a much more extended time frame after surgery. And this fits well, I think it was mentioned early on, about the bundling of payments over a larger period of time. This then would fit that very nicely. So I thank you for your time, and stay tuned. This is a very rapidly moving program, and we're quite excited about where this might go. The next step will be thoracotomies. Thank you.
I have a quick question.
Yeah.
In terms of level of activity, do you measure that in addition to the reported pain scores?
Well, we didn't specifically measure general activities. What we did is we had the very specific walk for 15 meters when the clinic visit was present. We plan on doing that in subsequent studies to look at general activity regimen. We were trying very carefully in these studies, as we've learned from other settings, other drugs, not to load any one study with too many inputs, so we're going iteratively to add the components to it.
Okay, very interesting presentation. I have one comment and one question. The first comment is related to the fact that you have an half-life of 2 hours, which is, I am not surprised, because your site action is not the CSF, it is the spine. Then it's not surprising that if you inject a compound, you will see the compound binding to the tissue, the receptor side, and that's really, if you wanted to do something, will be the site where you want to look at the half-life, not the fact that it is disappearing 2 hours in the CSF. The question that I have is, I just want to prepare you, although I'm not working for the FDA, but there is a lot of information in the literature saying that whatever treatment you do, especially for knee replacement, at 6 months, everyone is the same. That you may want to have discussion with them about this 3 months limit that you want to study, because I personally will say 3 months may be the definition of chronic pain, but I want to know, especially in this new class that you define, because you are defining a new class, if it's really make a difference at 6 months, which is where everyone say whatever you do before 6 months doesn't matter because everyone comes to the same level.
Well, so let me address those one at a time. The first is the half-life. In the tissue, the half-life is less than 2 hours, in fact. This has to work intracellularly, so it needs to get into the cell. The half-life in the CSF is relevant because of the gradient to get into the cell. And in fact, we have a significant amount of evidence that the site of action is actually the dorsal root ganglion and not the dorsal horn. So we have access through the CSF since the DRG sits inside the dura. So the half-life, the point being a short half-life with an effect that you can see out. This exceeds the preemptive analgesia definition by orders of magnitude. The other point is the definition for chronic pain. Now, the FDA has been quite clear in their initial information that 3 months is the requirement for chronic pain. If, for instance, all subjects, which doesn't occur actually, but all subjects come back at 6 months, that would not be consistent with the 20% incidence. Of course, going to thoracotomy, 50 to 80% would be different. But let's look at the subject or the person that would receive this. If their pain would resolve at 6 months, should they exist with the pain at 3 months, 2 months, and earlier? If we can bring this incidence of pain from a mild range for 100% of subjects earlier, say within a couple of weeks, that certainly would be an appropriate treatment, as opposed to just waiting for 6 months and everybody's going to resolve. So in fact, there are 2 opportunities here that we've been counseled for potential breakthrough designation. One is changing the slope of the postoperative recovery curve, and the second is prevention of chronic pain. Whether that be 6 months or 9 months, given that in the literature, incidences of pain after total knee replacement are stable from about 30 days out at least to 6 and 9 months. I'm not too concerned about it. But of course, this was the appropriate model first because a large number of people were already receiving an intrathecal injection. Going to thoracotomy or surgery of that sort with a much higher incidence of chronic pain would be great. We now have seen, these data notwithstanding, in the normal healthy volunteer and so on, we saw no hypotensive effect, no respiratory effect, no cardiac effect. We fully expect that being able to use this intrathecally before, say, a thoracotomy, as long as you're there, you can be injected in an hour or more before the surgery. So in fact, it shouldn't interfere with the surgeon's activity. So it's, whether it be 3 months or 6 or 9 months, I think we would be in good shape. Holding patients in the study that long could be more of a challenge. Thank you.
Yeah, I'm very impressed about the data, and I mean everybody who's interested in the development of chronic pain after surgery should be, because I have never seen this before. I have several questions to you, and maybe we can discuss this later on, but my favorite one is, and you mentioned just thoracotomy or mastectomy, where patients have huge, not just intensities, but we have an incidence rate of 50% or so. And we have a high incidence of neuropathic chronic pain. Do you think it works the same in this population? Because after total knee replacement, we don't have much neuropathic pain.
The way this compound was discovered and screened was in the spared nerve injury model, preemptively before that. We also used the knee surgery model that Bhuvan Endran's group had published with a spontaneously behaving animal. We have used inflammatory models, the CCI model, it all works. And in fact, the paper that was published in Pain in 2014 is an interesting paper in the sense that the venture capital investors required us to reproduce the data. So within that one paper, you have 3 or 4 labs, very well-known labs, that have reproduced the data, and it's all within a single publication there. So we're confident in the neuropathic component of it, but in fact, that would be more exciting. One thing I should say is that there's an intervening study we have to do before thoracotomy, and that's distribution. One of the things we know about this formulation that we've developed is that it is heavier than heavy bupivacaine.
Okay.
This is 1.047 as a density, which is actually an advantage, because what we can do is inject the lumbar, lateral position to the patient, slight tilt, and then flip supine, and we lock it in the thoracic region, which is perfect for breast surgery and so on. The reason that we didn't go breast surgery right away is that in thoracotomy, higher incidence of chronic pain, but we also have a very clear cough and deep breath, have a mechanically evoked pain component. It's less obvious, although possible, of course, in breast surgery.
Okay, if I can ask the second question, if you are targeting so many targets, basically, some are maybe involved in pro-inflammatory processes and anti-inflammatory and in wound healing.
Interesting.
Check that?
Yeah, so that's the beauty of an agent that's injected intrathecally that doesn't have systemic exposure. Right, because
that's correct, but maybe by central, yeah, I know, but...
So what we are, first of all, we have not seen and looked for those adverse events in the clinical subjects. The other point is that it's a transient effect. Now for EGR1 being induced, that's okay, that's beautiful. In the periphery, there may be housekeeping activities such as wound healing that a transient hit won't influence it. The other thing that encourages us is the knockout animals do not have those issues. Two things they have actually. Don't sensitize with trauma, and they don't form long-term memories. This agent does not get in the brain because of the heavy nature of it. We've looked at the Wechsler battery, and we've also done the in humans, the Morris water maze in animals, and there's absolutely no effect. It tracks with placebo.
So what's the careful in children, maybe?
I'm sorry?
In children, careful?
So in children, this will be an interesting issue. It would be a smaller dose. You notice that the dose we're using, 660 milligrams up to 1,100 milligrams. What limits us is endotoxin limits. We can't put 5 grams. But because of the formulation, nobody's ever been able to get to a gram of oligonucleotide in the CSF without problem before.
Yeah, thanks.
I thank all the speakers, and we are pretty much right out of time for a coffee break. So thank you.